So I'm very happy to preside in this session with Dr. Saridákis. Dr. Saridákis is the president of the Greek Oncological Society. She's a very well-educated physician, of course, and very broad-minded. And we're very happy to have you and the other speaker today here. Dr. Saridákis, you want to say a few words?
Well, Dr. Emmανουηλίδης, thank you very much for your kind words and your kind invitation to co-chair this very exciting session. We are always glad to have scientists from our neighborhood, I would say. I feel Israel is very close. And of such an expertise that can really lead us through what's there to expect with this very, very important and, unique, I think, aspect of oncology treatment as the TKIs. Dr. Emmανουηλίδης has always selected very intriguing titles for his congresses. He has a sense of looking at oncology from a different angle. So I'm really glad that I'm co-chairing with him, and I'm looking forward to your speech as well, of course, as the speech of Elena Maragouli, who is known oncology in Greece, and especially in GU.
Let me say, thank you, Dr. Saridákis. Let me say that Dr. Peer comes from Israel. She's the director of clinical research at Rambam Health Center. Is that right?
Yes, absolutely.
And let me tell the audience, because they don't know, Rambam is the colloquial name for philosopher Maimonides. Is that right?
Yes, absolutely.
He was a very important Jewish scholar born in Spain, in Cordoba, in the 11th century. He is famous as a theologian, also as a philosopher. And he was a broad-minded person and very active in intellectual pursuits. And he brought together Aristotle and Judaism and philosophy and theology. He was a very, very open-minded person. At school, we learned about him. During my times, school, we learned a lot of things at school at that time, at high school. So it's very nice to have a person from that institution that bears a very, very important name in the history of mankind. But today she won't talk about philosophy or theology, she will talk about TKIs in kidney cancer. Please, Dr. Peer.
Thank you so much. So I'll talk more about philosophy of treatment. It's amazing you studied Rambam in school. It doesn't happen these days. You're absolutely right. Let's see. Okay. So you see. Okay. You see the full screen or the presenter mode now. Okay. Wonderful. Okay, so really, thank you so much for this invitation. It's so kind of you, and I'm very excited to take part of your meeting. So, as you mentioned, I'm a GU oncologist at Rambam. I run the GU clinic, and I also run the clinical trials in oncology. So I'm very lucky to have a good experience with the new drugs early in the development. We have a phase 1 unit, first in human. So it gives us a lot of experience, and we are very fortunate to have access to the drugs. These are my disclosures. Most importantly, Greece is my favorite place. I spend every year a month in Greece, and this is my house in Sigri, Lesbos. This is a view from my house. But I'm sorry to say that I still didn't get to learn my Greek, but this will happen one day. These are my additional disclosures. And okay, and now we can start. So RCC and TKIs. I always take it back to the basic. that we have to remember that RCC is highly vascular tumor, and this hardly changes. Most of the tumors, they tend to be extremely vascular with necrotic center. And when we look at the tissue, in the tissue of the VEGF concentration, it's predominantly high, extremely high, 1,000 times fold than other tumors. And this is a very unique feature of renal cell carcinoma. This actually summarized my lecture that TKI cannot fully be replaced unless it's a subset of population that really drive a full benefit and pronounced prolonged benefit from IO therapy alone. But the mainstay of patients are dependent on activity of the vasculature, and this is why we have so many drugs that block the VHL activation system in one way or another, versus trapping the VEGF, inhibiting one receptor or another, or the new drug that suppress the HIF-1 alpha signal. So, but still, everything is around this activity of the vasculature. Of course, this is, I call it step one for the vascularity, but step 0 and step 2, because interferon was the only thing we could give back then. And today, combination with the IO is a mandatory treatment for most of the patients. Because tumor inflammation and the complex system with numerous incision points of immune therapy is the hallmark of the tumor progression in renal cell carcinoma, along with other tumors, as we all know. So when looking at the frontline treatment in advanced RCC, still we have two landmarks that are very significant. 2006, when we started to treat with the TKIs, pazopanib and sunitinib, and other came later, mTOR inhibitors. And later on, in 2018, earlier we had the immune therapy back in our toolbox for our treatment. But I think the main change in the way we treat our patient comes in 2018, when we started to use combination therapy. And if not in the front line, maybe in the more advanced line. But this is here to stay, the combination therapy. And this is, I think, the most important landmark for us. So I will touch on the TKI role in different steps and different areas of treatment. We'll start with the localized RCC in the adjuvant setting. And this is where, unfortunately, numerous studies failed to show real benefit, pronounced benefit with the TKI treatment as a single agent. We have unmet need for treating the patient with a high-risk feature in localized disease, as 50% of them with a high-risk feature will eventually progress to metastatic disease. Also, there's a subset of patients that have resectable metastases, and the standard of care is still to follow up on this patient. So, unfortunately, TKIs did not really penetrate the arena of localized disease. There are many studies, but I'm showing the highlight, especially the ESTRUC study, with showing some disease-free survival benefit, especially in a very high-risk population. But this does not translate to OS benefit that is significant. And therefore, TKI in the adjuvant setting is reserved for very limited group of patients. There was a trend a few years ago to give it more than the data supported, but this has subsided with the entrance of new data for immune therapy. So in that era, the Keynote 564 study for adjuvant pembrolizumab did show a pronounced difference in disease-free survival for this patient. The overall survival data is immature, but this has become now the main option to consider for patients with high risk or M1 resectable disease for a duration of 1 year of treatment. And the guidelines, the NCCN guidelines are updated, supporting the patient with high risk features. The priority recommendation would be for adjuvant pembrolizumab, but this is still lacking in OS data, and we have to wait to see real data. In Israel, adjuvant pembro is not covered, the adjuvant TKIs are not covered because the data is not robust. Sometimes in the M1 setting, we treat them as if we treat metastatic disease, but we don't consider, this is not covered yet with the limited data. So for moving from the localized disease to the frontline treatment in metastatic clear cell RCC. So let's take it back a minute to the clinic. I have with a patient that I'm treating, one of my patients, this is a young patient, 45 years old male, with ICD due to VF and anticoagulant therapy. Although he's young, he still have a heart complication. And this poor guy was diagnosed with a clear cell metastatic disease, intermediate risk, one factor. He had a nephrectomy, and soon after, we actually spotted a large mass in his left ventricle. So this is a rare presentation of metastatic RCC, but there are some case report supporting that metastases in the left ventricles are possible sites of metastases. He has some also lung metastases. This is not a single site. And because we sampled his lung, and very adjacent to the left ventricle, which was positive to clear cell RCC, but we couldn't diagnose the left ventricle because it was too risky to test. So we test for echocardiogram, which was not compromised in its ejection fraction, but still with a large mass that we see in the cardiac CT very clearly. It's a significant mass in his left ventricle for a young patient. This is not a disease that we can follow up. So what are the treatment options for such a patient that comes to the clinic? He's in the frontline setting and he needs systemic therapy. Well, the guidelines today support combination therapy in the frontline setting. It could be IO-IO or IO-TKI, both the EUA and ESMO guidelines, and of course the NCCN guidelines support the priority of combination therapy with the immune therapy-based treatment. For selected patients that cannot be treated with immune therapy in combination setting, we offer single agent TKI, and all TKIs are possible with priority for intermediate and poor risk for the cabozantinib. But these are very, very selected patients that are usually not fit for such therapy. With the updated data for the combination therapies, all show robust, consistent results with over the years, with the IO-IO, with the ipi-nivo having the longest follow-up of 63 months. This is the longest duration that 68 actually, but we follow up these patients, and the data is very robust, and the patient that responds to therapy still did not reach the median duration of response. So this is a very, very specific combination, very powerful for the subset of patients that do respond well. But all the other combination are TKI-IO, having the keynote 426 with the Axi-Pembro combination, the Checkmate 9ER with the Cabo-Nivo combination, and the CLE study comparing the Lenf Pembro versus all of them versus sunitinib at the control arm. And what we see is that the results are pretty much similar. There are some differences in duration of response, in complete response, and in toxicity profile, but we are eventually talking about similar neighborhood of results. Superior PFS, superior overall survival, and superior complete response and response rate. When we're looking at the length of pembro, we see more response rate and a little bit more toxicity. A higher response rate, but that comes with a price for all comers. So comparing across trials is always tricky, but I think it's inevitable that eventually we have to look at all the data and decide for a patient what fit him best. So we always have to remember that different diseases have different challenges, and a patient that has a bulky disease with limited metastases is very different than a patient with a small mass in his kidney with multiple lung mets or other metastasis site, comparing to patient that has bulky, very symptomatic disease that needs very, very rapid response rate. Each patient comes with a different profile, and eventually we have to take in a lot of things into consideration when we decide what's the best treatment for our patient in the front line. So this is a little bit the philosophy of the physician, because different physicians decide differently, and different physicians have different access to treatments, and there's no right and wrong answer for a patient. But each comes with his own background and decision-making together with the patient that help us decide what's the optimal treatment for our patient. So many factors need today to be taken into consideration. It could be the tumor characteristic, it could be the clinical characteristic, and external factors. What do we really want out of this treatment? Do we aim for complete response? Do we aim for response rate? Do we aim for duration of response, quality of life? Are we looking at factors like treatment-free survival, that this is actually one of the newest endpoints for a patient? Will he have a chance to be treatment-free with our treatment? Are we looking at low rate of progression disease? So many factors for the same patient, and the treatment decision is always complex. There's no really one size fits all for all our patients. I do want to stop for a minute and emphasize the treatment-free survival. I think when we talk about quality of life and toxicity, we always have to add into this discussion, what are the options for treatment-free survival? I think we all come to a discussion with our patient that they start frontline therapy. They are very anxious with their first scans. They see benefit. They go to the second scans and they see additional benefit. But very soon after that, the question comes, how long do I have to continue therapy? First, they really want to win this disease, win this battle of this disease. But after they get used to the concept of treatment, they are ready to discuss the concept of discontinuation therapy. And they, a lot of time, having a hard time with the notion that this is a permanent study. And when we can discuss option to be treatment-free survival, I think this is going to take, with the patient living so much longer, this will have to take a center stage in the discussion with our patient. We know that ipi/nivo doubles the chance to be treatment-free survival compared to sunitinib. The data is still not available from the TKI because it's too early to discuss that, and the more than 5 years follow-up enable us to understand the importance of IO for a subgroup of patients. So really, when we talk about the options still today, the durable response for a patient comes from the combination of ipi/nivo. However, the response rate is lower than the TKI, and the chance for progressive disease is higher. And this puts a burden in the decision when the patient has a high burden disease or a specific disease site that are not suitable to take a chance of progressive disease and response rate that is lower. However, when we aim for long-term this is still an important, very important treatment option. When we look at TKI-IO, so all show benefit, as I mentioned before. And when we look at toxicity profile, again, toxicity profile is similar, except for the lenva-pembra that shows a little higher toxicity of grade 3 and more. And I think you all know it from the clinic that lenva is a more challenging TKI, but it just requires more communication and more help with adjusting the treatment and managing the side effects. Very few patients in my clinic had to discontinue therapy, and the more I treat with lenvatinib in the front line, I realize that more and more patients can actually tolerate the full dose of lenvatinib without dose reduction. And this is very different from my experience in the second and third line treatment. Quality of life, as I mentioned, is very important to me. So I always put the slides of the toxicity and the quality of life. And this is where I pulled the 9ER study, the Nivo-Cabo combination, which is one of my favorite combinations for the patient, because it's not just the data presented, it's really my experience in the clinic that the quality of life with this combination is very, very good compared to what we know with the other TKI. And this does not come with a compromise in response and durable response for the patient. When we look at the toxicity profile, it's similar to the sunitinib. This is a drug that we've known for 15 years now, and we are very well experienced with adjusting and managing the side effect. So the combination and the toxicity doesn't come with a heavier price, although the Cabo is given at a reduced dose of 40 milligrams. In the recent ASCO GU, the final overall survival for the 9ER was presented with a subset analysis of the response in the different organs. So I put everything, most of them except for the lymph node in one slide, that we see that the superiority in response is robust in all organs, whether we look at the kidney, the liver, the bone, or the lung. The Cabo-Nivo is superior to TKI single agent, and the decision for combining such treatment is not reserved for one specific disease site of a metastasis site or another, because we see in this analysis that the superiority for this combination is across all borders. So when we have to make a decision at the end of the day, there are pros and cons for the PD-L1 CTLA-4 combination or the PD-L1 VEGF. And when we look at the TKIs in the subgroup, we're looking at the profile of toxicity and what suits best our patient, whether we want combination of different TKIs is really an ongoing open question, and there is no right and wrong answer. Some of our patients are challenging. One of my patients is an older lady. She's 85, she's very fit, but she has metastatic RCC. She's symptomatic with dyspnea. What we did when we diagnosed her, we follow up. We put her on surveillance for several years. And the surveillance was actually the best option for her for a long time. But eventually she became very symptomatic with her breathing, and she had more dyspnea and pleural effusion. And this was a time to treat her. We discussed that with her, with her family. They opt for treatment rather than best supportive care. So when you have this older population, what would be the best option for them? I think it's very tempting to start with immune therapy with less complication than the TKIs. And this is exactly what I did with her. I actually started with a single agent Nivo and thought I want to add later the EP, which is one of the options from different studies. But she did not respond to immune therapy, and then you had to take it to the next step. So what do you do when immune therapy combination doesn't work in the front line? If plan A doesn't work, we shift to plan B. So when we take it to the second line setting, there are multiple options in randomized, well-designed controlled arms that show that we have different options, that eventually we continue one TKI after another, and all these options are good options in the era of TKI in the front line. But what happens in the era of TKI that is, what do you do with the second line setting post TKI IO combination or IO combination? And this is an open question for us. One of the randomized study, one of the phase 2 study, non-randomized study, 1B2 study, treated lenvatinib with pembrolizumab for patients with advanced line that previously received immune therapy. And they received, most of the patients were in the 4th or 5th line of treatment. And this is where we saw first that lenva-pembro is a very potent combination, even in the post-IO setting in advanced line, with up to 70% response for these patients in the advanced line post-IO. But when we look at single agent TKI, there's a lot of retrospective data, so many studies that published similar data. This is one of them. I didn't bring, of course, all of them, but there's so many of them, so it's really hard to bring everything to this lecture. But post IO, we expect a response rate of about 35%. When we are post IO TKI, the response rate is lower, but patients do respond. There are plenty of study that tells us that response for TKI, post TKI IO is there, and whatever you didn't give in the front line, you give it in the second or third line. And if you can combine therapies in a more advanced line, this is also an option that is now being explored only in clinical trials. And there are so many of them. So one of the last questions is, what do we do in the non-clear setting with the RCC? So one of the study explored the option in the papillary, this option in the papillary 1 and papillary 2 setting, where the MET is a single signal that is very pronounced in both disease, more in papillary type 1, but also in papillary type 2. And the data I'm showing, I'm pulling the more important study, the ECOG study that actually shows that unlike lung cancer, we should not be tempted to think that RCC is personalized like lung cancer that was presented in the presentation before me. And eventually, for fertility, the crizotinib and savolitinib were discontinued because of fertility, and sunitinib and cabozantinib were compared in the patient with the papillary metastatic RCC frontline setting. And this study showed that cabozantinib shows a superiority over sunitinib in the median survival that actually shows really good results compared to the other competitors of 9 months of PFS, which was very impressive for the papillary population that we're expecting with other retrospective data about five months of PFS. And this study really put the cabozantinib in the front line for treatment of papillary RCC. There are many subsets of non-clear, and for each one of them, there's a different philosophy how we treat it. The guidelines tells us that still the standard of care is monotherapy, TKI, sunitinib, cabozantinib, pazopanib, or any of those. And the ESMO guideline tell us that in an advanced papillary setting, the preferred option is cabozantinib. But does it mean that this patient should not receive IO TKI combination in the frontline setting because of the lack of data? It's an open question. In Israel, luckily, we are not limited with the histology, and we have the registration per disease. And so the frontline setting do allow us to treat with the combination IO TKI, although the data is not there, but the data is coming. So, and there's a lot of data out there already showing supporting that IO is active in non-clear histology. And I'm not talking only on subchromatid, but the other sub-histology. Of course, subchromatid is really important, but the other subset do do respond to immune therapy. So when I treat the papillary in the front line, it's off-label, but we treat with, I prefer to treat with the Nivo Cabo. I think this is a good answer. The data is coming and we have to wait for the Nivo Cabo and other studies and also Pembro length, and we have to see what happened with that. So unfortunately, at the end of the day, we still, unlike lung cancer, we don't have a direct driver to tell us a mutation that tells us how to treat exactly each patient. And the tailoring of the treatment has to be very, very, is very complex. We have to take a lot of things into consideration, and we don't have a simple answers. So my conclusions are, when looking at TKI in adjuvant setting, it's a no, and only selected patients are eligible for TKIs, and more patients will start with adjuvant immune therapy. Luckily, there are a lot of studies that we have availability to explore these options. In the frontline treatment, TKI, absolutely, in combination with IOs. What happened in advanced line? TKI is the standard of care, and what happens in the clear cell, in the non-clear cell RCC, TKI are the mainstay of the recommendations. So we'll finish with what the future holds for us in the treatment of metastatic RCC. Many open questions and a lot to be done still. In the localized disease, a lot of additional studies coming. One of them is a PROSPER study, important ECHO study that we are lucky to take part in. This is also already close for accrual, and this is actually exploring the role of adjuvant and perioperative nivolumab. So the patient received nivolumab prior to the surgery of nephrectomy, and then post-nephrectomy once a month, compared to the standard of care, which was radical nephrectomy alone. It will take time for the results, but results probably will be in a year or two. Another interesting study is a MSD study with anti-HIF alpha belzutifan, which is a new guy on the block. And so this is another competition to the TKI in a different action of mode, but shows a promising efficacy in advanced line, and now it's being explored in the adjuvant setting. For this study, they will receive the patient, this is already open for accrual, and the patient, all of them receive Pembro for 1 year, and 50% of the patient will have addition of belzutifan. This is a daily pill of 120 milligram compared to placebo. And it's a little more well tolerated compared to the TKIs. It will be interesting to see how this will affect the patient. At the end of the day, we hope for more molecular subset of renal cell cancer that we know about how they will direct our decision in a better sense, that we will have a better understanding which patient need the angiogenetic inhibitor and which one need the combination IO or IO alone. This is around the corner, but this is, I think, the most important thing for us when treating RCC. Maybe the answers will come from the triplet therapies. There are numerous studies addressing the triplet therapy. So maybe if 2 are so good, maybe 3 will be even better. The first study that will be published is a cosmic study, Ipi-Nivo Cabo versus Ipi-Nivo and placebo. This should be published at the end of 2022, end of this year, and it'll be very interesting to see if this is translated to more efficacious combination. My experience with this study is that it comes with a price of toxicity, but it will be extremely interesting. The future holds a lot of different combinations. There are MSD, numerous umbrella studies that are looking at length Pembro with multiple combination and different IO targets. But at the end of the day, nothing is really impossible. And I'm sure eventually we'll have beautiful results of cure for a metastatic patient. So with that, I will conclude, and I thank you. This is a Rambam Center. We are at the Siad, northern Israel in Haifa. This is a tertiary center that treats a population of 2 million. And the oncology building is right behind this tall building. So, Afarastopoli. Thank you.
Thank you, Dr. Peer. Well, we thank you for a very insightful presentation about the role of TKIs in renal cancer. Of course, they're indispensable. Let me ask you a few questions. First of all, VHL. Do you check all patients for VHL mutations nowadays? Or you don't?
I don't.
You don't have
No,
to?
I don't, because it's not going to change the way we treat the patients. So eventually they will be exposed to IO and TKI. So since eventually it doesn't really make a difference in the way we treat them, we don't do genomic testing for a patient.
Okay. Second, what about adjuvant treatment with a combination of IO TKI as an adjuvant treatment for high-risk resected renal cancer?
Well, it's very interesting. My personal feeling is that this is something to be considered for M1 metastasectomy patient, but at the end of the day, this is a toxic therapy. One of a recent patient that we started adjuvant Pembro was hospitalized after 2 cycles with myasthenia gravis, full blown. And this is always a reminder that, you know, immunotherapy is not water. And when you throw into this bowl the TKI with the toxicity of TKI for 1 year for this patient that have actually no disease, I think it's going to be very challenging. And I think it's better to wait for the result of the Pembro or the Pembro and the anti-HIF-alpha before we run to adjuvant therapy that is so toxic.
Good point. I had a case like this for metastatic disease too, myasthenia gravis. We dropped the TKI, the IO, and the patient progressed eventually. He got a lot of corticosteroids. It would have been nice if we were able to identify in advance who would be the long-term responders with the IO-IO combination, so that we avoid the higher number of progression, because we do have more progressions with IO-IO.
Yeah, absolutely. I fully agree. It's really frustrating that you don't know, and this is what we really need. We need an accurate biomarker and a profile that really helps you. And I don't think that testing for VHL alone is the answer, is because I have this slide that I showed, there's no switch on and off for this patient. And we don't really know, and this is really what we need. But still, for patients that don't have high burden disease and are fit, not even fit, but there's no high burden disease, they're not symptomatic, I still prefer IO because it's the durable response option, which I think that this is what I wish for the patient. If it doesn't work, we'll switch for TKI.
Yeah. Okay. Any questions from the audience or from my co-chair?
Can I ask a question, please?
Of course.
Sure.
Do you believe? I'm wondering why some of the combinations are there for the intermediate or the favorable. And if we take out the way the clinical trial was conducted, do you see another reason why some combinations are indicated for intermediate and some are for all comers? I mean, is there any specific TKI or combination characteristic that makes us use it in these populations, or is it just the way it was set up to be addressed?
Well, I think that the TKI show benefit across all borders, and before we have a follow-up of at least 5 years for these studies, we cannot really discuss what happened with survival for favorable. But and for median favorable, this probably will take longer. But we have to remember that still there's a good portion of patients that active surveillance is good enough option for them, and we don't have to rush into treatment. And those patients that relapse also very, very late, post-nephrectomy, years and years later, or they the pancreas, indolent disease, these patients will usually respond less to the IOs. And this is a more TKI-driven disease. But still, for those patients with the indolent disease, personally, I'm never tempted to treat. I always try with the patient, if it's asymptomatic, to put them on surveillance. And when the time is right, usually a single agent TKI is good enough for them, because this is really angiogenic driven disease. And there are a lot of studies published on this issue, especially the pancreatic lesion, that show less response to the IO. We don't have to jump on them with a combination with the option for toxicity. And I think this is in the Checkmate 214, the population of the good risk has really compromised the data there, because the patients are not the same.
Yeah, thank you very much for this. Thank you.
Very, very useful discussion. In the interest of time, we have to go on. Thank you again, Dr. Peer.
Thank you so much.